What's the most important thing we do as endodontists?
It's not the root canal.
It's not the instrumentation.
It's not even the obturation.
So what is it?
It's the diagnosis. Because it doesn't matter how well you execute the procedure if you treated the wrong tooth.
So where do most clinicians get it wrong?
And what separates the way a specialist thinks from everyone else?
These are the conversations that don't make it into the textbooks, but they shape how we practice every single day.
Welcome back to For the Love of Endo. You've got to be locked in because every little thing is significant when you're cultivating a diagnosis.
There is a lot of philosophy in endodontics. I mean, I know we practice in science and we have the literature here to back us up, but there's a very philosophical aspect of what we do. And a lot of it comes down to the diagnostic process. I know that the revenue that we produce in clinical practice is based on the technique and the actual root canal treatment itself, but the value of what we do is really in the diagnosis. Because I don't care how good your root canal looks or how well you executed your technique. If you treated the wrong tooth, you've kind of missed the boat. And I think that diagnosis and case selection is really important. Where do you think that most clinicians make a lot of these diagnostic mistakes?
Well, first and foremost, I believe in the biggest differentiator between the specialist and the general dentist. Sure, the technical skills are enhanced, but it's that clinical decision making, it's that diagnosis. So I think one of the biggest things is when things are not in absolution, you have a hyperemic pulp, you have a irreversible pulpitis with an extended cold response, you have percussion sensitivity, and you have no lesion. A GP can handle that. But what if you have all of those pulpal symptoms and tests, but then you also have a lesion?
The diagnostic value of things like cold testing, electric pulp testing is really valid if the results of that test are reflected by what you see radiographically. Because if you, to your point, if you test a tooth with cold and the patient feels something, there's a big lesion there, are you automatically going to assume that that's a non-odontogenic lesion?
Right.
Or is it a false positive? So these things just aren't black and white. It becomes really, really challenging. And the other thing too is with these diffuse issues of pain where people will come in and there is no obvious problem and they can't localize it. That's a real difficult situation to deal with as well.
For sure. And I think when I sit down to diagnose, it also requires a clean slate. Like whatever happened before that moment cannot be a part of it. And what's going to happen after that cannot be a part of it.
You bet. So do me a favor. Let me, from your perspective, your first-time patient comes in, never met him before. They sign at your front desk or whatever your intake is. What is the process from getting that person from the front desk to your chair and then you're walking in? What is all the stuff that's running in the background before Dr. Brett Gilbert walks in that room and says, "Hi, nice to meet you. How can I help you?"
Yeah.
Walk me through your intake.
Yeah, so the clinical assistants handle all of the initial upfront interaction. So they handle taking the triage in terms of understanding what's happening with the patient in their experience.
Give me details on that. I mean, what are they doing to triage? Do you have a form that they're following?
Yeah, they have a form that they follow, and they're very experienced, and they're really great, and so they know exactly how to sort of converse and get a sense of what's going on. So just a general sense. I'm not asking them to do pulpal testing. They also get a 3D image. They get a PA. And then they give me a report. One of the biggest pieces of information, Bill, is what's been happening with them. Like, did they recently have a crown? Did they have a root canal before? So getting some sense of the present moment and some sense of the history is pretty much what I'll walk in with. And then from there, start to do my own, conversation and detail. How about you?
Well, that sounds very similar to what we do. We've got a form that we've developed called the subjective patient questionnaire form, and I wrote it probably, maybe 15 years ago, and we had a list of questions that was asked in a specific order, and next to that question there was an empty box where our team member actually had to write the answer in, because we were finding that although they were interviewing the patients, by the time they came back and gave that information to me, there were things that were just lost in translation. Plus, by the time they actually had to write something in that box, that promoted active listening. And when people have active listening, they're going to understand understand a little bit better. Now, we've morphed that over time into a digital form, but I'll bet you're very similar. Like when your team member has done the intake, because you're getting all your radiographic information prior to you going in that room.
Yes.
We have a standing order in our practice that everybody gets an x-ray as a prescription because it's efficient that way. Going to get an image from me.
Yeah.
So why do I need to go in and waste everybody's time? When the patient says, it's this tooth here, I don't need to go in and look at the tooth. I just need an image to see if the tooth is treatable. And so that's very similar. But I will sit at my desk and I'll be pouring over that cone beam volume. I'll look at the bite wings, I'll look at the PAs, while the team members chatting in my ear, reading off the information from that diagnostic subjective questionnaire, and I've already formulated my diagnosis before I've even walked into that room. And that, I would say, probably is greater than 95% of the time. Would you agree with that?
Yeah, I would. And the other thing that's funny about what you're saying is I think sometimes the GPs don't realize we're in that room teaching them. Well, imagine us working with our clinical assistants every day, year after year. We teach them, we've taught them, so they are an extension of us, and they understand what we're looking for, what the little buzzwords are. And so I think maybe if you haven't spent time in an endodontic office, you don't realize how highly trained the assistants are and how good they are. And I know some of my colleagues, those assistants do the tests.
Yeah, I do on my own.
Yeah, me too.
When you evolve your career and your philosophies on a stage, right? What I was teaching 20 years ago is different from how I'm teaching now. So when I used to say things like endo ice has no value, does it matter what the endo ice test is going to tell you?
Well, the contrarian view, and the reason that I do those tests is because it's great patient education. Patient, oh yeah, I felt the cold, but it wasn't too bad. And the second one you did, which is obviously the adjacent tooth, wasn't too bad, but wow, I really understand that I have a problem based on that. So that, to me, is worth the spray.
But what about the patient where you try to do your controls? They're not feeling anything.
Then, of course.
So your control value isn't accurate, then all the other tests that you do after that are devalidated.
Yeah.
Go back to the first thing you said, because we've had a conversation about this last year. We sat in a booth and talked about this together. Diagnostic terminology is changing. And you are on a committee that's now reshaping the nomenclature of how we're going to be qualifying pulpal status and periapical status. So first of all, two questions. Number one, when are we making this change? When is it going to come out? And number two, how difficult is it going to be for all of us to make this adjustment on the categories that we're going to have to quantify these diagnostic terms in?
All right. So technically, we are shooting that hopefully by the end of this year or the beginning of next year. So this committee started in 2023. So it's been working for 3 years. And just to give you a glance, if there are 8 people or 6 people talking over 3 years about 20 different terms, you can imagine how far away we were to be able to come closer to some agreement. So again, everybody is coming from different backgrounds, different opinions, looking more on the biology side, looking more on the clinical side, practicality side. So how to bring all these things together to bring really terms that could be of value. And I get it that in the US here, we've had our terms since 2008, 2009. It works to a great extent. We understand it very well. But if we really look at the overall improvement of it worldwide, I think it's good that we agree on a global level how we need to name things. We definitely had some limitations in the terminology defining certain conditions, defining, especially with regen endo, vital pulp therapy as a permanent treatment, how to assess cases that are not healing yet. What do you want to call them if they didn't heal yet? Should you call them asymptomatic apical peritonitis, which is acknowledging they are diseased, but you are not really doing something about them? So we try to add and plug in certain things, try to define things more in a more accurate way from our perspective. But there is still a limitation because our diagnostic tools still have not evolved as much. Beyond imaging, we definitely have improvement in the imaging space. But in terms of our assessment to the vitality of the pulp, probably we didn't really move far from where we were like 40 years ago. So I think there is still work in progress, but I like the fact that we can at least agree in every paper you will read, the term becomes standardized. You should not be opening the JOE and you see a term and opening the IEJ and see a completely different term.
Follow up to this here too, and this is the conversation we sat in the booth and had at the last AE. My biggest contention in a clinical diagnostic scenario is when
There's no lesion, patient is asymptomatic, and doesn't respond to any vitality testing. Now, I know it's not an official diagnostic term, but I've consistently for several years, as far back as I remember, called them inconclusive pulp status. So please tell me that that's going to be a new diagnostic term. Please.
I have good news for you.
Oh, I love it. I love it.
So actually, the term inconclusive is something I personally believe in as well. We published a paper back in 2021, trying to show exactly that this term is very important to be used, especially cases with trauma history, for example. You really don't know what's going on. Older patients who may not be responding as much, patients who are on radiotherapy for a long time. So these are conditions we know that the sensibility is affected, but the vitality is not. So inconclusive pulp status allow you to follow up. Same thing, inconclusive periapical status.
You wrote a fantastic paper that was published in Journal of Endodontics about fracture necrosis. And I think that's a landmark paper that I kind of hang my hat on too when I'm trying to make the choice about should we treat it.
Well, first of all, the fracture necrosis was a term that I coined, actually, meaning that a tooth would die because of a fracture, not because of deep caries or because of trauma, but because of a fracture. I was frustrated in practice just like you are. I would see a case that I treated nicely, 5 years ago, and it comes back and it's, there's a fracture in there, or there's a huge amount of periradicular bone loss all the way down to the apex to the crestal bone. I'm thinking, what the heck is going on with this? And I would tell them, I won't charge you for the consultation if you bring me back the tooth. Ooh, love it. So they would bring me back the tooth. And I'm looking at it, says, it looks fine. I would put it in bleach. I would dry it. And I would see this hairline crack going down the long axis of the root of the tooth. I mean, so small. But when you think about it, if you can see it, it's not as small as you might think. Then it's an avenue for bacteria to get into and cause that tremendous amount of bone loss. So then I kept doing that, and I kept seeing the same thing. It was almost 100% of these teeth that I thought I did a really good job on, that were nicely restored, and they would have a crack in there that I could see after the fact. So then I took it to the next level, and maybe I shouldn't have, but I did. I would have somebody come in that would have a virgin tooth or practically a virgin tooth, and I can't really see a crack or a fracture just clinically. But I would tell them, your tooth is non-vital, the tissues inside there died. And the only thing I can think of that would cause that tooth to die, because you don't have a restoration in the tooth at all, would be a crack or a fracture. I'm going to tell you, I don't think that the success rate for what I'm going to do is going to be all that great. And there's a way, I'm out of pocket. Don't have insurance. I don't want to pay, close to $2,000 just for the endodontics and then the crown afterwards, and then have maybe something that might not have a great success rate. So I'll tell you what, I said, I don't know that I would do it either, but I'm not going to charge you for the consultation today or the x-ray. After you have that tooth taken out, bring it back to me. A micro CT is different than a regular CBCT. CBCT will give you a resolution, a cutting of about every, 70 microns, 80 microns or so. But the micro CT is about every 6 microns. That's really small. 100% of those teeth that we put on the micro CT came back that there was a fracture that went right down the pulp, through that furcation area, and down off of a lateral side of a tooth, just like you would expect to see the bone loss in a situation like that. So we put together a paper on it and saying that if it's got no restoration and no other reason for the pulp to be necrotic, in all likelihood, this was 100%, you're going to have a crack or a fracture in that tooth. Now, you might be able to save that tooth, but when that tooth goes south, after the root canal is done, you're going to have a huge amount of bone loss that's going to compromise it for an implant. So my thought was, let's get those teeth out of there. I don't think there's a great prognosis, and have that done before you have that dramatic amount of bone loss, because once you lose crestal bone, it's really hard to replace, and your implant prognosis is going to be less.
So is your opinion different if you suspect a fracture? Let's say that all conditions being equal, and the only difference is vitality versus necrosis. Does it change?
My thought pattern changes.
How so?
If you have a tooth that's non-vital, even with a periapical lesion that you might be able to see on a CBCT and not see on a periapical, but if it's non-vital, my thought is that crack's pretty deep. But if you go into a tooth that let's say they have a hypersensitivity to cold, you know that there's some vital tissue inside there. Maybe that crack hasn't gone so far. So when you access that, you're looking around for cracks or fractures as you access it, maybe you'll see it. But if I get in there and it's bleeding, and for good reason, like there's a large restoration on the tooth or a crown, even though I'm seeing a hairline crack in there, I'm probably not so quick to condemn it because maybe that hypersensitivity that they're having wasn't coming from that crack. It might have been coming from the restoration or whatever. So
Fair.
I think the patients have a right to know.
I agree.
A right
Yeah.
to know what you're thinking about. Now, take that as it is. The paper was considered controversial when it came out.
Mm-hmm.
And on the first round of review, it was not accepted. One of the people that were on the scientific advisory board, one of the directors, he was pretty adamant that they thought that this paper had some importance to it. That's the reason why it was published.
So now cone beam rolls around. You get a patient comes in, well, my dentist sent me over here to find out if the tooth is fractured or not, right? And they said, you have this 3-dimensional image that can help me tell whether the tooth is fractured. And when I look at these images, yeah, we can see some indicators. Dr. Mohammed Fayed in Chicago has done a great paper on 5 indicators to suggest the presence of a fracture, one of them being seeing the frank fracture. But a lot of times we're not seeing it on the cone beam, we're seeing evidence of it. And when we talk to the patient and they say, well, my dentist said that you can see the fracture on the cone beam, why can't you? So where's this being lost between the referral and us and the communication to the general dentist is where do they think that we can just see all these fractures on the cone beam? Where does this come from?
Well, there's 2 mistakes here. One mistake is that we don't inform the general dentist as much as what we're thinking about. Second mistake is holding a lot of water that the CBCT is going to show us that. Think of it this way. Your CBCT is making slices every 70 microns. That's the width of almost a number 8 tip of an endodontic file. It's pretty small. But you're not going to see certain images in the CBCT unless it's twice the voxel size. So if the voxel size is 70 microns, you're not going to see it until it's 140 microns. That's about the width of a number 15 file tip. So if that crack is smaller than the width of a number 15 file, you're not going to actually be able to catch that on a CBCT. The only thing that is going to help you out with in that regard is if you can see periradicular bone loss in the CBCT that you're not going to be able to see on a PA. And that's where it can be really helpful.
Is periradicular bone loss a deal breaker for you for treatment?
If there's a reason for that periradicular bone loss, for example, a large periapical lesion that extends up into the periradicular bone loss going to the crestal bone, and if my thought is that's caused by a deep restoration, deep caries, crown on the tooth, it's not a deal breaker for me. But if somebody says, I don't see a crack or a fracture, I can't see anything clinically, but I take a CBCT and I'm seeing a lot of width in that periradicular area, all things considered, I'm thinking crack or fracture in the root. So yeah, it's a deal breaker for me.
So then when you have those scenarios clinically, you're talking to the patient, identifying risks and benefits, and you can say, well, Mr. and Mrs. Smith, I suspect there could be a fracture. I can't guarantee there's a fracture, but if there is, the less likelihood of this working, then you put do you give this information to the patient, let them make the choice, or you try to direct them in a specific direction? How do you manage those?
I direct them because I think it's our job to tell the patient what I'm actually thinking and what I think the prognosis is. If I say there's a crack, I think there's a crack or a fracture, I don't know, I don't see it, but it's your call. If we do the root canal, it might not work. And if it doesn't work, it's going to take away a lot of bone. It might compromise it for an implant, but it might work also. You have to make the decision yourself. I don't buy that. I just don't. I think that the patients come to you not for your treatment, but for your expertise. And I think you should guide them if you think it's not going to work, because their obvious question to you should be, what would you do if it was yours? Exactly.
Heard that before.
Exactly. All the time.
Yeah.
And if it were mine, I would hate to lose a tooth.
Would you try to save your tooth?
No. At my age, I probably have another, hopefully 15 to 20 years left. If I were 80 years old or 85 years old, that's also a different scenario. So somebody like that might say, you think I can get another 5 years out of it, maybe 8 years out of it? And my answer would probably be, it's certainly possible. But for someone who's a younger person, they might not think along those directions. So there's a lot of different parameters that are involved.
Interesting.
Really
I think I'm young enough to last it maybe another 30 or 40 years. So
Well, you got the passion.
It's
you
a
got
gross
the energy.
exaggeration, but yes.
I think I would try. I think I'd try. I think I'd try to save my tooth.
Yeah,
I think I would.
I
mean,
think it's a personal decision.
Well, and
so
then, but
there's
the
nothing
other
wrong
side of
with
the
that.
coin is you're a dentist and you're going to watch that like a hawk. And you're not a patient that's going to skip their recall in 6 months or a year or 2 years. You're going to follow it up. And if it starts to break down, you're going to get that thing out of there right away. But you're an exception to the rule.
But when people ask me that question, here's my answer to the patient. I take risks with my teeth. And I'm willing to take those risks because I know that the outcomes can be pretty nasty. And I have taken risks with procedures, and I haven't won them all. So I try to get that patient involved with the decision making. I don't want to tell somebody it's not going to work when there's still some questionability to it. But I really like your approach. I really think that that's a really good way to guide them. Right?
Works for me.
And it's a fascinating conversation. My reflection, Lou, just listening to you, like I know your paper on fracture necrosis, but getting the bandwidth to like have the long range that, hey, I'm gonna start to collect some of these teeth. I'm curious enough, right, to start to think, hey, maybe once I collect enough of them, maybe we can learn something. I don't think many people do that. So I really acknowledge what you did there and ultimately made a great contribution to our specialty.
I think it's our job to look out of the box a little bit.
Good for you, man. That's why you're a leader.